On January 31st, 2025, I was invited to speak. I was the anchor speaker, the last speaker at the Penn Neuro-Oncology Symposium. And I wasn't going to post this, but my patient called in and just let me know that she really enjoyed my talk and really was excited that I was able to present. So I figured, let me share that with you. Good afternoon. If you're hearing this video, it's because I'm literally stuck doing brain surgery at the other hospital, and I want to make it, but I don't know if my timing's going to work. So I pre-recorded this talk. This is the day before this wonderful neuro-oncology symposium. I want to thank Dr. Hubling, who's leading the panel, as well as all of the organizers of the conference. So my talk today is about the optical evolution in neurosurgery. So we need to be able to see to operate. And I want to dumb this down and then take you to a journey where we can see the invisible. That is what is exciting. So let me get to my first slide here. So I practice at Pennsylvania Hospital. This is the first hospital in America, and you can see the front garden and the facade of the front. It's a beautiful building, but if you look up, you'll see the surgical amphitheater. The surgical amphitheater is one of the first in the nation. It's placed all the way up high. And why is it placed up high? It's because you need to be able to see. The surgical amphitheater was used in the 1800s. The gas light was only introduced in 1830. But if you go to the building, which you can tour, you'll see these beautiful clerestory windows and all of the natural ambient light that is needed to be able to operate. And surgery really is the story of light. You can only do surgery back in those days at high noon, and then all the observers were trying to learn and watch. The anesthesia was primitive in those days. Now, in order to be able to see and do brain surgery, that was such a revolution. It really required a revolution because one thing is you need to be able to study anatomy before you can operate on it. So Leonardo da Vinci was very unique, obviously a master anatomist, but the brain is interesting. It decomposes really fast. And so in order to study brain anatomy, you have to have ways to preserve it, and formaldehyde and all of those methods didn't arrive until later. So one thing Leonardo da Vinci did in the 1467 was he injected the ventricles. Now that's these areas in the brain that are full of cerebrospinal fluid. He injected it with hot wax. By injecting it with hot wax, he could get the shape of the fluid-filled portions of the brain. By doing that, he was able to learn about the lateral ventricles, the third ventricle, and actually give us some insight into what brain function or brain anatomy was. And then we have to go further along. Now we're like 500 years later. Golgi and Ramon and Cajal, using the Golgi stain technique, they can now see neurons and describe all of the beautiful dendrites and axons. And so you can see here, it's important we have to be able to look to be able to understand. Walter Dandy now in the 1919, he now understands the anatomy of the ventricle, and he puts a ventriculoscope into that location, and he can then do the procedures that we currently do today. In fact, I was one of the first surgeons at Penn to do endoscopic third ventriculostomy. I had learned it in Pittsburgh, where I trained, and I brought it here, and actually nobody was doing it. I know I did the first one in the adult side. Even on the pediatric side, it was not commonly done here until one of the pediatric fellows, Dr. Green, came. So this is just an example. We're in deep into the third ventricle, opening up a hole, and this is just an amazing technique that we can use once you can see, once you can bring light into the ventricle. And Dandy published multiple papers on hydrocephalus. Now, another way to see into the brain is to look at anatomy. And Egas Moniz won the Nobel Prize, but not for his technique for visualization. He won it for frontal lobotomy. And that's a whole different other story. And actually, what really stands is today, and that we continue to use, is his technique of cerebral arteriography, where you inject a dye into the blood vessels and you look at the blood flow, and that shows you beautiful anatomy. Now, if you want to take your phone and take a picture of this, this will take you to my YouTube video of where I visit Egas Moniz's home, summer home, and where all his Nobel artifacts are stored and all of his historic documents. And it's a really fascinating story of an incredible man. And this is just a snippet of the YouTube video if you're so inclined. Of course, we now rely on axial imaging with CAT scans and MRIs, and both of these are Nobel Prize-winning procedures. I really credit Lars Leksell, who did amazing work using even ventriculography in that day just to visualize and treat. This is actually a picture of our gamma knife units being installed. So we still use this to target tumors. Now, optical imaging. I am a hobby photographer. Here's a picture of me like when I was really young. And I'm a hobby photographer. I love to take pictures. I have, back in the slide day, I would shoot Kodachrome, Fujichrome, and then look at it on the light box that you can see there. And we really rely on these revolutions in optics. We have to be able to see. So in 1957, Ted Kersey was a neurosurgeon, and he literally just brought in a microscope that's being used elsewhere, brought it into the operating room. He revolutionizes neurosurgery in that era and that generation. So in this video, you can see a beautiful technique where I use conventional optics, just white light, beautiful illumination with the microscope that you saw earlier, and this tumor that's located deep. It's a fourth cranial nerve schwannoma. And you'll see my dissection technique. I just use my hands, my eyes, my tactile feedback, sharp scissors. Actually, I always joke, I studied all this molecular biology. I did all this research in labs. And at the end of the day, all I really want are sharp scissors. But this is an optics talk, so we're looking at the visualization, we're looking at the sharp scissors dissection, removing this tumor off the fourth cranial nerve. It's a gorgeous dissection, and I'm deep in the brain. I am on this patient's midbrain. And I'm just carefully pulling it away. This tumor, fortunately, has a very beautiful capsule. It's not invasive and malignant. You don't need CAR T. You don't need immunotherapy to cure this patient. You need a great surgeon. You need excellent hands. You need good technique. And you need to be able to see in order to provide excellent result. And that's what I'm doing today. And I think that's why I'm closing the session, because we've talked a lot about all of the complexities of neurosurgery and neuroscience and brain tumors. But at the end of the day, for the right tumor, just finding the right surgeon is super important. And here you go. Here comes that tumor coming out here. I've preserved all of the important anatomy there. It's a gorgeous result, gorgeous resection. So the story for how I started on this process of working on dyes to make the tumor glow, to see beyond the visible, starts with a friend of mine, actually a high school friend of mine, Sunil Singhal. So let me show you that. So this is the Lawrenceville graduation, which is my high school, and there's 4 surgeons in this picture. The middle 2 are me and Sunil, who are classmates in '90, and then his older brother, cardiac surgeon, my younger brother, who's a plastic surgeon. And so these 4 children of immigrants, we met, and we started collaborating. So Sunil introduced me to this technique of injecting a high dose of dye, and it gets stuck in the tumor. It gets stuck in the tumor such that we can see the dye in the tumor, and it allows us to make sure that we get a more gross total resection. And this was the cover of the 2019 Journal of Neurosurgery or Neurosurgery. And we recognize, and a lot of people have talked about the challenges of glioblastoma, so I'm not going to get into that. 5-ALA is currently an FDA-approved drug. It's somewhat expensive, and this one drug actually is the only approved dye for tumor visualization. This is me standing with Walt Tumor, who is a German neurosurgeon, standing in front of the beautiful Pennsylvania hospital, and the CEO of the company. And they were initiating a new clinical trial using this drug for another tumor type. And Walt Tumor is really credited with pushing the envelope for 5-ALA. And it's a valuable technique for tumor dissection and identifying tumor, but it's a very dark dye, a little bit sometimes hard to see. You have to work and be able to operate in very dark conditions because you only want to shine with a blue light in order to see the red light. So can we improve upon that? And additionally, 5-ALA really doesn't work for tumors that are non-contrast enhancing. There's actually a recent study in Nature BME suggesting that 5-ALA and the protoporphyrin 9 actually is not even located in the tumor itself. It's actually located in the immune cells that are digesting, probably processing the dye. The other reason to get away from 5-ALA is that the visible light spectrum is very complicated. is a lot of fluorophores. In fact, when you use 5-ALA, sometimes you'll see green pigments, you'll see other colors, yellows, and that's because of autofluorescence or other, you'll sometimes see collagen or lipopigments. And so there's a reason to get away from that and move to the near infrared. 5-ALA is not a very bright dye. Indocyanine green that I tend to use is much brighter. Actually, fluorescein is extremely bright dye, and I know Dr. Amankalor loves to use fluorescein, although its specificity is probably less than ICG. The technique we use for ICG relies on the EPR effect. Permeability, so just like when you go to get your MRI scans as a patient, they give you that dye leaks into the tumor. Same thing with ICG, our dye, it leaks into the tumor, and that allows us to visualize. This is a flank model that we were using just to proof of principle to demonstrate our technique works for tumors. And this is my student Steve Cho doing all this research comparing 5-ALA to ICG, and it has distinct differences in how it contrast enhances. We chose the best camera for this particular topic, and this is the particular company. And we chose the one with the widest dynamic range and the most sensitivity. It had both an endoscope and a exoscope. Actually, many of these cases I can do with both techniques. The optical environment is complicated. One problem with this is that all of these lights, LEDs, sunlight, fluorescent bulbs, they all have mixtures and contaminations of light in the near infrared. So sometimes we have to shut off the lights. We have windows in our operating room, so we have to close those windows. That makes it a little bit complicated. We call this tumor glow. It's been trademarked here at Penn, and we had a huge study. Dr. Stephen Brem recruited a lot of patients for this, and we conducted this last decade. And so this has been very useful. So for example, this is a patient with glioblastoma. This is the tumor. You can see the contrast enhancement in the gadolinium. There's a thin rim of tissue or brain, normal brain, between me and the tumor. And when you open it up, all I see is normal brain. I don't know where exactly the tumor is. I have a rough estimate because of my navigation system. But when you turn on the laser, because we're using laser for high output power in order to excite that fluorophore, it returns a near infrared signal that we can detect. We can then superimpose that image on the white light so that we get a sense of exactly where it is, and boom, there's a tumor. It's a beautiful technique. Then I go ahead and resect the tumor with just my traditional techniques using a microscope, and then once I'm done, I look for more dye. Is there any dye left over? And then boom, there's the tumor there, so we know we got to remove that. I'm trying to make surgery easy. I'm trying to make it like a cookbook so that we can do great results without being too complicated. Here's another patient. This is a 21-year-old female. She has 2 areas of enhancement. You can see one in the lateral and one in the medial. And I resect this frontal lobe en bloc, and here you can see there's tumor confined to the small spot and the big spot on one on lateral and one on the medial. It's a beautiful result. So we did this in 80 patients, including Dr. Stephen Brem, and we got great results. Our tumor to background ratio is excellent. We can see through the dura. We can see through cortex. So even before you open, you can see where the tumor is because the wavelength is long. It allows us to see. So we published this result many years ago. We also showed that this can predict your post-op MRI so that you can look for residual enhancement. We show that this can be used for any contrast-enhancing tumor in the brain, such as brain metastases, lung cancer, breast cancer metastatic to the brain. We've also shown that it can work with meningiomas. So here's an example. This is meningiomas actually are the best. They're so bright. They're so beautiful. Claire is now, she was a med student at the time. She then spent 3 years working for McKinsey Consulting, and then she came back and decided to become an ophthalmologist. But she made this video, and here the near infrared has no specific color because it's a wavelength that we can't see with our eyes. But when you just make it a grayscale, then you can color map it and make it the brighter areas more red and the lesser areas more purple, and then that gives us some ability to superimpose the images and do the surgery. And here you can see me cutting out the dura, removing the tumor, and the visualization is fantastic. And now the tumor is out. So I want to thank my student who made this video, Claire, and our research team at the time. As you can see, there's a lot of excitement for dyes. This is this is Journal of Biomedical Optics. We publish our we've conducted courses here, and there's a lot of future steps. We're doing a lot of work to use ICG at lower doses on the same day, and that study should be coming out very soon. Lifetime imaging. I have a collaborator at Harvard who likes to use ICG, and he believes that it's a very specific marker, especially if you look at fluorescence lifetimes. I have another collaborator where we're conjugating different things to create brand new dyes with excitation in new wavelengths, and it's a very exciting time. Please feel free to follow me. This is my YouTube link. Take a picture with your camera, and periodically I'll come out and I interview my patients and ask them how they're doing. So thank you very much. This has been a wonderful opportunity. Let's move on to the panel discussion, and I hope that I'll be there for the panel discussion, or I'm on my way.